Welcome to the StillsNow podcast for December 2023. Hi, I'm Jack Cush with StillsNow. That's right, I have another website called StillsNow.com, and we do a monthly newsletter and podcast that you can subscribe to either on your favorite podcast channel or go to StillsNow.com and sign up for the newsletter so you'll see when that comes out. It's got a lot of resources about Still's disease and autoinflammatory conditions, including new regulatory decisions and new articles that help to clarify the diagnosis and management of these very difficult disorders. In this podcast, brought to you by RheumNow Live, January 27, 28 in Dallas, Texas. You can register at rheumnow.live. In this podcast, we're going to review some of the highlight abstracts that were presented just last month at the ACR annual meeting in San Diego, held November 12th through the 16th. Great meeting, a lot of great content. We've done reviews for you on a lot of subjects, but here's a review on Still's disease and autoinflammatory disease. So let's begin with, I think I have about 8 or 9 what I thought were highlight presentations that you should be aware of. First is actually a rehash from EULAR 2023 in Milan, where abstract 0761, Bruno Fautrell and a number of co-workers presented the EULAR press recommendations for the diagnosis and management of systemic onset JIA and adult onset Still's disease. These are guidelines that are really instructive, tell you a lot about the condition and the approach to the condition as coming to you from the world's experts on this. I think it's a really nice document, a really good guide to therapy. The highlights of this abstract were the following. Number one, they say emphatically that systemic JIA and adult onset Still's disease are the same condition, and henceforth they should be called Still's disease. Still's disease in a kid, Still's disease in an adult, it doesn't matter, it's all Still's disease. I think it's a very important point that the FDA and the other regulatory agencies have really signed on to. Second, that you should, I like to teach that you can consider the diagnosis of Still's disease by having a triad of typical fever, typical rash, and polyarthritis. I like their criteria better. They say a rapid diagnosis of Still's disease can be considered, and strongly considered, when you have the quotidian fever, 1. Second, the typical JIA rash, that salmon pink, evanescent, comes and goes. And thirdly, high levels of inflammation. I like that. That means, extreme elevations of sed rate and CRP and extreme elevations of ferritin. Don't get too hung up on ferritin. Many of you do. The sed rate and CRP are enough to make this diagnosis, but they're going to be very, very high, like higher than PMR high, right? And if you got a ferritin of 20,000 and no other good cause, then congratulations. But that's going to be 1 out of 20 very sick patients with Still's disease. The other thing that they remind you of is that you should look for MAS in everyone, and that you should be aware of this lung disease that accompanies especially kids with systemic JIA and Still's disease. They say that first-line therapy is no longer, methotrexate and steroids, and boom, go right to a cytokine inhibitor, either an IL-1 inhibitor or an IL-6 inhibitor, with or without steroids. First-line therapy, it works. Why not use it first? And lastly, they remind you that if you have a difficult patient, someone who you say is difficult to diagnose and or treat, and or someone who has MAS, macrophage activation syndrome, and or someone who has a lung disease associated with Still's disease, those people really do need to be referred to and managed by an expert Still's disease center. And, you can ask around and find out where those are in your state, in your town, in your country. Second abstract I like actually sort of reinforces this point that adult and kid disease is the same. It's abstract 0758 and says there's no difference between the two. And that's based on a meta-analysis or systematic review of 8 studies and nearly 1,000 patients. And they say that, when you look at this, there's really no difference in the pooled estimated prevalence of all the symptoms of the two, systemic JIA and Still's disease, with the exception of prodromal sore throat. Second, myalgia. And third, weight loss. These are more frequent in adults with Still's disease. That's really important and something we've been teaching for a long time. Our next abstract worth noting is abstract number 2473, and it's a consensus algorithm on how to diagnose systemic JIA patients who have this lung disease. It's rare. It does occur. We're starting to see cohort studies that are better defining the syndrome, trying to get a grip on what is the exact pathology and the driver of this. This was a multi-center expert panel that reviewed a lot, the literature first, and then cases, and then came up with this algorithm. 1, you have to have systemic JIA. 2, those people need to be treated first line with either an IL-1 or an IL-6 inhibitor. But then you got to look for the red flag features. Any of these or all of these should be reason enough for you to refer to a pulmonologist and a Stills expert center, preferably a rheumatologist-run Stills expert center. This would include very young age of onset, less than 24 months. The HLA-DR beta 115 allele, there's a few of them, but HLA-DR beta 1.15 is the one you worry about. Trisomy 21, high disease activity, especially the presence of macrophage activation syndrome. A new atypical rash, eosinophilia, anaphylaxis, respiratory symptoms, the presence of pulmonary abnormalities on exam, or clubbing. Like half these patients have clubbing. They all have, abnormal chest x-rays and chest CTs. They all have very abnormal bronchoalveolar lavage. So these are the features that one should look for. It is debatable whether or not HLA typing is needed or not here. There are probably more studies right now that say that it's not that predictive and it doesn't pan out. There are some people who believe it does, and there was a report from the University of Minnesota where they had a much higher rate of HLA-DR beta 115s. And so, okay, that's probably, the beginning of a cohort of evidence that we're going to have to weigh. But right now, I don't think you can say that haplotype is a risk factor for certain. Eosinophilia seems to be a risk factor. Some people believe prior treatment with IL-1 or IL-6 inhibitors may be a risk factor for the development of this condition. So let's move on. I have more on this lung disease in a few more abstracts. Abstract number 4, 1932 is the abstract number, talks about the impact of initial ferritin levels on the disease and its complications. So they did a study of 185 patients with Still's disease, and they were typical. When you look at all their numbers and the demographic profile, it looked typical. Median white blood cell count was 12,000. That's about right. Median CRP levels were about 16, right? The median ferritin levels were 6,700. Out of the 185, it looks like 44, so that looks like, about 30% were admitted to the ICU. If you were an ICU admitted Still's patient, you are more likely to have higher initial ferritin levels greater than 6,000. Also, those who were initially admitted to the ICU with Still's disease were more likely to manifest MAS or HLH, DIC, disseminated intravascular coagulation, and pleural effusions, but not pericardial effusions. But the point being that extreme elevation of ferritin should be a gigantic red flag for MAS or HLH, but should also be a severity marker, because again, I've always said that you want acute phase rectal Still's disease, 95% will have extreme elevation or high SED rates in CRPs. But only 50% are going to have an elevated ferritin, and that's elevated ferritin, like more than 1,000, but extreme elevation or hyperferritinemia more than, I think the number is 10,000, or extreme elevation, that's an even lower number. But the fact that it's lower means it's a more select group and they're more likely to have more severe disease and end up in the ICU. I think that's an important teaching point. Next abstract, 0348. I actually talked to the authors of this abstract. I found it interesting because it kind of jives with what I've been observing when I'm treating these patients, and that is the use of ruxolitinib, the other JAK inhibitor is used to treat myelodysplasia and hematologic indications. It was used to treat 3 cases with systemic JIA that were refractory to typical therapies. And by that I mean steroids, immunosuppressives, other cytokine inhibitors. There were 3 patients between ages of 5 and 15, 2 females, 1 male. For instance, one patient had SJIA, recurrent MAS, fever, hypotension, despite treatment with anakinra and tocilizumab, and then had MAS. Ruxolitinib added to the regimen. It seemed to work. I'm an advocate for the use of the JAK inhibitors. I've used mostly tofacitinib, but I believe that they'll all work. Here's now evidence that ruxolitinib works in the treatment of either the MAS complications of stills or really problematic stills. I really would like to see some studies of this rather than what we're seeing here and in other reports, which are just case reports, and sometimes that's the best you can do. Next abstract, 0358. The clinical and baseline features and biomarker features of a systemic JIA lung disease patients coming from the CARA registry. That's the Childhood Arthritis and Rheumatology Research Alliance, or CARA. They do a lot of important research in pediatric rheumatology. They identified and enrolled in their prospective registry 37 patients from 16 CARA sites in the United States. 46 had biopsy-proven lung disease, definite lung disease, 36 probable lung disease, 18 suspected SJIA lung disease. The ones who had lung biopsy, all of them had alveolar proteinosis and interstitial inflammation. 40% had fibrosis. But what we're seeing here with this lung disease, it's got a number of different presentations, and whether it occurs early, whether it occurs in young people or older. Again, I think there needs to be more research on this. The interesting thing about this lung disease cohort, inside having serious lung disease and a high risk of hospitalization and death, is that they're at a much higher risk of developing MAS than patients without lung disease. In this study, 77% had one definite episode of macrophage activation syndrome, and I think that that's worrisome, right? In these cases, the MAS occurred prior to the lung disease in 70% of the cases, and coincided with the lung disease in 18%. Another study from Bracaglia et al. 095 talked about their cohort from European centers, 17 pediatric rheumatology centers, and they compiled a list of 49 kids with SJIA lung disease. The median age of onset was 7 years, and 27 of the 49 had a chronic persistent course, meaning more arthritis, but 38 or 77% had active systemic JIA at the time of diagnosis. About the other half of the patients had polycyclic or inflammatory episodes. So 21 out of the 49, and so about 40% of the patients. So again, the lung disease becoming active at the time of the diagnosis, 77%, that seems high to me. And the rest, there were no others that developed it after the onset, and then 84% developed MAS, and what's this? And then a few of them died. Again, the bronchoalveolar lavage was done in a subset of 22 patients, and that was, again, told us about alveolar proteinosis. Vasculitis was found in one, fibrosis in a few others. Again, 47% of these people required ICU admission, and 18% died. So this lung disease is a serious deal, and that's why the recommendations, the EULAR press recommendations, they got to look for this and really have a high index of suspicion about this. We had a few abstracts that talked about, actually one abstract that talked about predicting success with anakinra or IL-1 inhibition in 39 patients with SJIA. That's abstract number 036 by Nardini et al. And out of their 39 patients, about 25% flared when anakinra was withdrawn, and flared about 8 months later. So I like that number. I always use the number, how long is this disease going to last? And I say 8 months to 8 years. How long before you know you're out of the woods? And I say about 8 months, and I think that kind of says that here. But the number is 26% of people who they withdrew the anakinra for systemic JIA, and 26% flared within 8 months. What predicted the ones who didn't flare? Meaning you treated them for 8 months to 8 years, whatever you think, showed that they were in remission for a prolonged period, and then you decided to withdraw therapy. What were the features? Well, the ones who had shorter disease duration were less likely to flare. The ones who had early use of anakinra, meaning being used within the first 3 months of disease, compared to those who had anakinra after 3 months of disease, they had an 8-fold higher risk of flare than those who got it earlier. And also those who received higher doses of anakinra. Anakinra, you may need higher than usual doses. You could say the same for IL-6 inhibition, because these are hot inflammatory patients, and usual doses may not be enough. I think that's an instructive abstract. That's abstract 036 from Nardini et al. And lastly, there were a few abstracts about how Stills patients respond when they receive the COVID vaccination. One coming from the Reliance Registry. This is abstract 1842. And there's a large cohort of patients who receive canakinumab for autoinflammatory and periodic syndromes, so not just Stills disease, and they showed no significant risk of flare or disease worsening of their autoinflammatory condition with the COVID vaccine. Second, abstract number 097 did the same thing, looking at adults and kids immunized. I think it was over 100 patients who received the COVID-19 immunizations, and they only had, I think, one flare in those that were vaccinated. So again, you can vaccinate your patients with Stills disease using COVID as a test case here, and I certainly would recommend those patients receive the vaccinations that they are due based on their age and based on when those vaccines are available. That's it for this episode of the Stills Now podcast. Listen next month. Again, I'm going to put this podcast on the Room Now channel for others to tune in. But to remind you that if you want to get future Stills Now podcasts, you got to go to the StillsNow.com website or look for Stills Now podcast and subscribe to that, because we got a few of them coming up monthly that we started last month. We're doing this month. We got a few more coming in the months to come. Tune in for those. Take care.